structure of the heart itself is fairly straightforward in terms of sort of the lining, the layers, the muscle, and the vessels. It's quite self-explanatory with the reading that I've given you. But the way in which the heart works in terms of its contraction and relaxation, and also how that affects the rest of the circulatory system, is a little bit more complicated. So I thought I'd talk you through that a little bit with this video. The first thing we want to think about is the cardiac cycle, and the cardiac cycle is just another term for a complete heartbeat. So the contraction and the subsequent relaxation of the heart muscle itself would form one cardiac cycle. And the number of times that happens within a minute varies for different people, but in general, a complete cardiac cycle, so from contraction to relaxation again, is about 0.8 of a second. Your average healthy heartbeat in an adult is sort of 60 to 70 beats per minute, so 60 to 70 cardiac cycles per minute. The rate depends. When we're younger, it tends to be a bit faster because the heart muscle is smaller, so it's working harder. In adulthood, it slows down, and then as we age towards becoming elderly in our later years, it can change again, but that's often to do with disease process. If a heartbeat is particularly fast, we refer to that as tachycardia, and if it's particularly slow, bradycardia, but there's a sort of accepted norm of between 60 and up to no more than 80 beats per minute for a resting heart rate. Obviously, when you're running about and doing exercise, or if you've had a bit of a fright, then your heartbeat increases to increase oxygen flow around the body, but your normal healthy heart rate should be 60 to 80 beats per minute. When we think about contraction and relaxation of the heart muscle, we have two terms. Systole, S-Y-S-T-O-L-E, as you can see there, that refers to contraction of the muscle, and diastole is relaxation of the muscle. So we see we can split the cycle in half. Half of the cycle is systole, contraction, and the other half is diastole, relaxation. Systole itself we also split in half. The first thing that happens as the atria contract, so the smaller chambers at the top of the heart contract, and that's so that they can push the blood through into the ventricles. That's quite a quick motion, so that's just around 0.1 of a second. The atria are considerably smaller than the ventricles, so they fill up quicker, and therefore they've got less contents in them to squeeze through, so it's fairly quick. Ventricle systole takes longer. It's a much bigger chamber. In particular, the left ventricle, which is pumping blood from the heart to the rest of the body, is a big muscular part of the heart, so that takes longer, so about 0.3 of a second. Then the whole heart muscle relaxes and has a bit of a rest. And that's your cardiac cycle. When the systole occurs, so when the atria or the ventricle occurs, coincides with when they become full of blood. So the vessels that lead into the atria, whether that be the superior vena cava or the pulmonary vein, feed blood to the atrium. As soon as they're full, the pressure increases, and that causes the valves, the tricuspid valve or the mitral valve, to open, and then blood will flow into the ventricles. Once the blood has filled the ventricles, then the pressure increases, and because the valves only go one way, the tricuspid and the mitral valve remain closed. However, the aortic and the pulmonary valve will open once the pressure is sufficient, and then the blood will flow out of the heart completely, and it will all relax. So that's your cardiac cycle. You will have looked at this a bit in what you've done already, because I did ask you to think about how the heart beats and the electrical conductivity. As we spoke about when we were thinking about nerves, the heart muscle is cardiac muscle, and it is completely autonomous of the rest of the nervous system. It has its own pacemaker, and it will beat irrelevant of what's going on. Like I said before, you can have completely no brain activity but still have a heartbeat. And that's because of the electrical conducting system that exists within the heart itself. It's controlled predominantly by the SA node, or the sinoatrial node, and that is this pacemaker that we were talking about. A very small mass of really, really specialised nervous tissue that is within the right atrium. And it starts, each cardiac cycle, it starts off. The signals then pass through the either atria, because they're going to contract first, to the AV node, or the atrial ventricular node, because it lies exactly between the atrium and the ventricles. And the signal will then pass down through the septum of the ventricles and up either side to cause them to contract. So if you always remember that the atrium contracts before the ventricles, then it makes sense that the pacemaker should be within the atriums rather than the ventricles. And that's your heart conducting system in a nutshell, basically. Sinoatrial node produces the impulse, it passes through the atriums to the AV node, which then passes down through the septum and the muscular tissue on either side. You could go into that into an awful lot more detail, but cardiology is not only, it's not even a degree in its own, it's a specialism of a doctor on its own. So you don't need to go into any more complexity than that. Just as long as you understand that the heart has its own conductive system that's irrelevant to the rest of the nervous system. So this leads us on nicely to talk about blood pressure. When we're talking about blood pressure, we're talking about the pressure within the arteries. And that's because they have the blood that's come straight from the heart as it's going to the rest of the body. It needs to be pressurized in order for it to get where it's going to go. If there was no pressure, it would just sit and stagnate in the vessels. But the pressure from the heart, this constant cardiac cycle or beating, causes pressure to build up in the arteries. So when we measure blood pressure, we're measuring the force exerted by the blood onto the arterial walls. Now, normal blood pressure we refer to as 120 over 80. What those numbers mean? The top number is the pressure exerted on the arteries during systole. So whilst the heart is contracting. So blood is being forced from the heart into the arteries. So that's a higher pressure. The second number, so the underneath number, is the pressure exerted on the artery walls during diastole, so when the heart's relaxed. So it will be a lower number. So if we think about this, if we just write this down so that we can be clear, if normal blood pressure is 120 over 80, 120 is the pressure when things are contracting, and 80 is when it's relaxed. And that's a fairly standard blood pressure. We measure it using this piece of kit here, which is hard to say. It's a sphygmomanometer. And they come in two different forms. You get the traditional style one, which is sort of depicting here, which has got the dial on it, which shows the pressure, and then a tube that runs to a cuff that goes around the arm, and then another tube that runs to a bulb, and they inflate the cuff using the bulb. They squeeze that, they inflate air into the bulb, and the aim of the game with this rubber cuff, is explained quite nicely down here, is to actually exert enough pressure to completely close the artery. If you can completely close the artery, then you can measure the pressure when there's nothing going through it. So you completely close off the artery, then you gradually release the pressure, and the first noise you hear when you're listening with your stethoscope is the highest pressure number, and then you hear another sort of, it's like a beating noise when at the next pressure, and that gives you the lowest pressure. It's a very complicated way of taking a blood pressure, and unless you do it all the time, it's not very accurate. So much more commonly now, we would use an automated meter, and even when you're at the doctor's now, they'll generally use that, where they just put the cuff on, they press a button on the electronic part, it inflates, and it will read both parts of the blood pressure and then give you a reading on the screen. It's doing exactly the same thing. It's still inflating the cuff to the point where the artery is occluded and then gradually releasing the pressure, but it's measuring electronically, so it's more accurate. So people tend to use those these days. It is still a sphygmomanometer, but it's an automated one rather than a manual one. Now, blood pressure does vary. Even in health, blood pressure varies. So time of the day, you'll have a lower blood pressure in the morning than you will during the day. During the night, your blood pressure when you're asleep is at its lowest. Partly because we're generally lying flat. If you're lying flat, the heart doesn't need to use as much pressure, particularly to get the blood to go up the way to your up and then down to your limbs, to your arms, sorry, and up to your brain. But even just the lower limbs, when you're lying flat, you don't need the same amount of pressure. Secondly, the heart rate is at its slowest whilst we're sleeping, and therefore the pressure will be lower in our vessels. So your blood pressure will increase as it goes on. Posture as well, like I was saying, when you're lying down, your blood pressure will be lower than when you're standing up. And that's why you need to sit people up slowly when they've been lying flat in the chair. Because whilst they're lying flat, the blood pressure is very low and it takes time to acclimatise. So if you jump up out of a chair whilst you've been lying flat and all of a sudden stand up, you feel a bit faint because your blood pressure is a bit low for what it needs to be when you're stood up. So that kind of whole stood up too quickly feeling a bit faint is because of postural differences in blood pressure. Other variations in blood pressure come with gender. So men generally have a higher blood pressure than women, ever so slightly. That's because men have bigger hearts, because they tend to have bigger bodies, bigger vessels, so more for the blood to pump round. So bigger heart, slightly higher blood pressure. Also with age, our blood pressure does increase with age. Remember when we spoke about connective tissue and elastic connective tissue, and we said that the walls of arteries contained a certain amount of elastic connective tissue that allowed them to stretch when they were full of blood during systole and go back to their original shape when there was when they were relaxing. Elastic tissue becomes less elastic as we increase with age. So therefore your vessels become less elastic and therefore they don't cope as well with the change in pressure, and blood pressure tends to be higher because the vessel can't stretch as much as it becomes full of blood. So it tends to increase with age. Other disease processes, however, can make it much worse or can actually go the other way and produce lower blood pressures with age. So naturally our blood pressure gets higher with age, but disease tends to interfere with that more. So with all this contraction and relaxation that the heart muscle's got to do and the electrical impulses it generates, obviously the heart needs a huge amount of nourishment. And we have talked about this previously, but now that we're thinking specifically about the circulatory system and the role that the heart plays in that, it's a good time to talk about the coronary circulation. So sometimes we tend to think that because the heart's full of blood, that obviously that's where it gets all its nourishment from, but actually the blood that's within the heart doesn't stay there long enough to be able to pass through the endothelial lining inside the heart and into the muscle itself. Also, the blood in half the heart, on the right hand side of the heart, is deoxygenated anyway. It's already been around the whole body. So the right ventricle would get very little oxygen and glucose from the heart, from the blood within the heart. So it has its own circulatory system that we call the coronary circulation. And it branches from the aorta. So as soon as the blood comes out the left ventricle of the heart, there's a branch that comes off, or two branches in fact, the right coronary artery and the left coronary artery. And they come down either side of the heart, they branch in the vicinity of the area where the heart splits into atrium and ventricle, and then they come and they spread a big network all over the heart, like a spider's web that comes across the heart. And they are what supply the heart muscle with its nutrition itself. When people suffer from conditions like angina and they get pain in the heart muscle, that's happening because the heart muscle isn't getting the nourishments it needs. And that's because the coronary vessels are really quite small, given the amount of work they do. They're very narrow and they are easily clogged. And they're clogged with things like cholesterol. It's generally to do with a poor lifestyle. So a high cholesterol, high saturated fat diet, and not enough exercise. Something that an awful lot of us in the Western world are guilty of. And it builds up in these coronary arteries, and then they become narrowed, and the heart muscle doesn't get the nutrition it needs, and then you get pain. Just like you get lactic acid build up in your skeletal muscle if you're doing a lot of exercise and you get pain. The same thing happens with your heart muscle, and it real tight crushing pain. If the artery becomes completely occluded and that piece of the heart is not getting any nourishment at all, that's when you get what's called a myocardial infarction. So infarction means a blockage. Myocardium is the muscle of the heart. So there's a blockage between the coronary circulation and the muscle of the heart, and it's not getting any circulation at all, any nourishment. And then that part of the heart will essentially die off, and you get heart failure. And if that goes on for long enough, you'll have a heart attack, and the heart potentially will stop beating altogether. So the coronary circulation is really important, and it's important to look after our health in order to look after the coronary circulation. And just for completeness in terms of the learning outcomes, we also were mentioned the pulmonary circulation. Anything that's pulmonary refers to the lungs, as you've probably discovered when you've been thinking about the pulmonary vein and the pulmonary artery. So the pulmonary circulation is when the blood comes out of the right side of the heart via the pulmonary artery. It passes through the lungs and becomes oxygenated, and then goes back via the pulmonary vein to the left side of the heart, from which it's pumped around the rest of the body. So the pulmonary circulation is as it leaves the left and comes to the right. Interestingly enough, the pulmonary circulation is the only place in the body where you have an artery carrying deoxygenated blood and a vein carrying oxygenated blood. What truly defines an artery and a vein is arteries take blood away from the heart and veins return it to the heart. So that's still the case with the pulmonary circulation. The artery takes it away and the vein returns. However, the oxygenation and deoxygenation is reversed because the purpose of the pulmonary circulation is to oxygenate blood that's already been around the rest of the body. The rest of the circulation is known as the systemic circulation. So we have the coronary circulation for the heart, the pulmonary circulation through the lungs, and then the systemic circulation where it comes out of the left side of the heart through the aorta, round the whole body, comes back via the inferior and superior vena cava and enters into the right hand side of the heart again. So that's covered all the learning outcomes for this section now. As always, you can put together your own notes, any questions, and we can talk about it at our tutorial. Thanks, bye.